few months, if not years, of their experience. So actually trying to live a life as a couple in a ward is quite something, isn't it? So that's just part of the great adventures that that kind of typified Ben's life. I heard somebody say recently, to think you work in medicine and won't feel pain is like swimming in the sea and think you won't get wet. I must say, I think Ben, his life has had a fair share of that. I think if you try to do what he has done, you can't do that without risking and with taking great risks. And with that comes great rewards. So when I walked with Ben and I said to him, "So Ben, what do you want me to tell them about you?" He said, "As little as possible." And I think that maybe typifies his life. I don't think Ben wants me to try and portray him as the biggest hero of the story. I don't think there's another reason for Ben trying to do what he does, other than him trying to be a life of thankfulness towards God. So I hope he doesn't mind me saying that as a personal testimony. I think that is exactly why Ben does what he does. He is just doing what he thinks is faithful and obedient, and with the consequence that Zitulele Hospital started off with a doctor living in the ward to now being a flagship hospital. I don't think he will take the credit himself. I think with him and his formidable wife, like I said, and a very strong team, he managed to do that. And that's what we're looking forward to hear about, Ben. Thank you very much for joining us, and we're looking forward to a night of adventure with you. Thank you.
It's very nice to have some real life people in the room. And for those of you online, I'm told the camera will keep an eye on me. I'm just going to try and share my screen. Amanda said it was easy. We're running. Still not. It's in presenter mode. What am I missing?
I think they are seeing it in presenter mode.
Are you seeing it in presenter mode, Amanda? Oh, you are? No, you're not. Oh, there it is. Oh, third time lucky. Okay, good. Am I speaking to those guys or these guys? No. So thank you very much for the invite and Kobus's kind words. I think you're right about rural medicine. It's a place where you get extraordinary opportunity to interact with the realities of pain and suffering and our world and our country. And the rewards are incredible, but it's also really tough. And so, you know, this is exactly what was on that kind of abstract in the flyer that went out there, and it's not really to read, but especially to say that I certainly don't come with the answers. And also, you know, trying to think, like, how does one approach a topic like this, or what should we be saying? Yeah, okay. I didn't want to stand here and tell you stories because I think we each have our own stories, and we can encounter those stories reasonably quickly and easily when we walk into a ward and get our hands dirty with patient care. There's so many stories to be had, and you know, you will already have your own stories, and there are more stories waiting to be written. And so I wanted to kind of approach this in a way, I suppose, if you know anything about our time at Zitulele, and particularly about the way I conceptualize our work, this is probably more of a talk on leadership, but maybe from a different angle, and certainly from the angle that I hope gives you tools to kind of approach the overwhelming challenges of working, especially in the public sector, a little bit differently. Because I think at the end of the day, we, jump ahead to the last slide, we can't meet the need. You know, is insufficient resource in the world, be it financial or human resource, our time and our energy is just not enough to meet the need to the standard that we would love to and that we get taught to at medical school or whatever other health discipline you happen to be. The reality is that we know the gold standard. We aspire to do the best, and that's good. And it's good that we want to treat people well. One of our sayings at Zitulele was Njengo Sisiwam. It was a measure of, is this care good enough for my sister? Is it good enough for me? And if it's not, why not? There might be legitimate reasons why it's not. My wife and I suppose, but me, we didn't deliver our kids at Zitulele because we had our kids when we just got there, and we didn't really have a great maternity service, and we didn't have a neonatal service whatsoever, and all our kids were prem. So that wasn't, it wasn't good enough for us. But by the time we left, it was the norm for doctors, nurses, every health professional to deliver their kids at Zitulele, or to be admitted in the pediatric ward if your kid was sick, because the care was good enough for us. And so it's kind of a dichotomy that you have to, on one hand, aspire to something more, and on the other hand, be able to survive it. So I'm going to circle back to that, but I think that the journey to that space is actually about leadership. And what's important is that we don't see leadership as something that one or two people do. So, back in the day, or very simplistic models of leadership, just these kind of autocratic, is it democratic, or is it just, a title and not a whole lot of direction? Okay, you might have heard it spoken about as sort of task-focused or people-focused leaders, as if there's just two types in the world. And there's a lot of merit even in this kind of model, if you think about where the focus is and what the strengths and weaknesses of people approaching leadership in this kind of way are. But, the more you start to dissect the detail, the more you realize, wow, there's a whole lot of complexity here. And actually, we lead in very different ways that aren't easy to categorize into 2 or 3 boxes. So I'm not going to go through this in detail. And in fact, my intention tonight is, as I said, not to give you the answers, but hopefully at least to whet your appetite or stimulate your interest to think differently about the way we lead. And as you will see, and I say it a bit more explicitly later on, my assumption is that we're all leaders. And we can come back to that. But, this has got those autocratic and democratic ones there. You can see them on the kind of 4, 5, and 6 o'clock on the circle. But there's a whole lot of other ways people lead. They're bureaucrats, close to my heart, not. Where there's a focus on paperwork. And we had one of these hospital accreditation organizations come to us when we'd been there for about 9 months. I mean, we were killing ourselves. There were 2 of us at that point. We were trying to develop services from just about nothing. And they asked us if we had the minutes of our perinatal meeting. And I was just pretty chuffed that we had started perinatal meetings and that we were starting to see an interest in analyzing that kind of data. And they said, well, if you don't have minutes, you might as well not have had the meeting. And I was like, oh, well, that's in your world, but that's not in my world. And you see, they were a bureaucratic, paperwork-focused leadership style. And that's not, I don't think, the best way to lead people. Okay, I mean, there's a place for standard operating procedures and whatever, especially if you can get someone else to write them. But it's the interaction with people that is going to come out time and again here, because when we talk about doing what we can with what we have, the reality is that what we have in our hands is sometimes very little. It's not a political myth that we're running out of money. Even the Western Cape, and if you're not from the Western Cape, you will know this, but if you've been in the Western Cape for any length of time, you might have forgotten how different it is. But even the Western Cape has significant budget cuts. It's not a joke. There really is less money, which means that what you have, whether it's staff or the physical resources that you need to do your job, or new equipment or whatever it is, or any equipment at all, is significantly less than that ideal. And that's why I think that doing what we can with what we have has to start actually inside us. And don't worry, I'm not going to preach a sermon, as tempting as much as it sometimes sounds like it is. Okay, no, it's not tempting. This book, there are a million books on leadership. If you just Google like books on leadership, there's enough to read a book a week for the rest of your life. And it's hard to know which ones are good, okay, and which ones are helpful to you in your setting. But this book was profoundly helpful to me and to our team. It's actually written by a South African guy, Brett Johnson. He lives in California, so you might not realize he's South African, but he sort of came up with this approach to leadership that breaks us all down into 5 categories. Okay, there's the luminary, that's the visionary person who sees the big picture and the future and is, come guys, let's dream together, let's make this happen. There's the E, the entrepreneur. That's the person who gets real energy out of starting something new, okay? New projects, new ways of thinking about it. They're the really go-getter businessman, but their strength and their passion is not keeping it going, okay? They're moving on to the next thing, okay? The manager is the person who likes to get the ducks in a row and let's do this day in, day out, keeping the show going, okay? The organizer, that's the more lists driven. Give them a list of things that need to be done. They'll make it happen for you. They run out of energy as the list gets nearly done. You might have had builders like that, for example, 95% done, the job's done, we're on to something else. But the organizer is excellent at making sure the tasks happen. And then the networkers. And this was a challenging category for me because I wasn't a networker. I'm still not really a networker. But some people are born networkers and they lead by connecting people, okay? And creating opportunities or finding the opportunities in those relationships that then lead to something else, okay? So that might be the person on your team who you think like, yo, they spend so much time talking to the nurses. I wish they would just see some patients. And that might be true. It's necessary that everybody maybe contributes to seeing the patients, but their bent is networking, connecting people. And the premise of this book is that we're all leading. Yeah, even you, little one, are leading. And I can't see it is, so I can say things like that. The premise is we're all leading. And for us to understand how the people around us lead is super important because we're part of a team. Wherever you go, you're going to be part of a team. Okay, even if you set up a solo private practice, the chances are you have someone at the front desk answering the phone, maybe a nurse working with you. Suddenly that's a team of 3. And it goes from there. So this book was very, very helpful to us. But the question is, if we're all leading, how do we fit together? And the kind of concept of values-based leadership and core values was one that we really just stumbled upon, to be honest. People sometimes ask me, how did you know what you were going to do? How did you come up with those plans? I think it was God's grace and kind of stumbling around in the dark and a combination. We just, the way we came across core values was really because as our team got bigger and more diverse, we realized we needed something to hold us together, to focus us. We came from different backgrounds. We spoke different first languages. We had different ideas, maybe even about what rural medicine was about. So how were we going to be a team? And we had one of our OTs actually facilitate the process of sitting us down and talking about what was important to us. And we're going to get into those in a moment. But this idea of needing to identify what is of primary importance to you as a team was hugely important. I'll pretend I can't see you, Amanda. And then allowing that to inform what we do. So you can see this is a kind of a informing, allowing our humanity, who we are, to influence what we do. And that reconnection with humanity is a huge part of allowing us to do more with what we have, I think. It's not about flogging the last little bit of functional use out of a human before they kind of exit because they can't carry on anymore. Because actually, you know, all of their usefulness, their productivity, their kindness, their humanity declines as they head towards the door. So you want to avoid those circumstances. And sometimes it's difficult to do that. But if we get our focus right and we infuse kind of what we're doing with a real sense of purpose, then I think we get a lot closer to kind of an ideal workplace, but one that also functions better. Besides, oh no. Oh, there it is. There it is. This is another document that I'd be very happy to share. It was actually put together by an organization called Africa Health Placements. Some of you might have heard of them. They don't exist anymore. They were fundamental in getting foreign qualified doctors to come and work in South African rural hospitals. Kobus will remember back in the day, once upon a time, makes us feel old. But anyway, in the early 2000s, about 75% of the staff of rural hospitals were foreign qualified doctors. Okay, you know, fast forward 20 years and we've got unemployed South African doctors, which is quite something actually, if you think about it. But getting those foreign qualified doctors here was a huge mission because the HPCSA and Home Affairs were not the most efficient organizations. And so Africa Health Placements did tremendous work in that regard. And they then became a little bit more involved with the broader HR picture with the National Department of Health. And they put together a document that was really intended to speak into the HR planning and inform HR policy at a national level. And they very kindly allowed me to edit it and put a kind of leadership bent on it. Okay, so this is an AHP document edited by me. But I take no credit for all the good things that I'm about to show you because that was in the document. What's useful, feels like there's a time lag here. Hold on. Did we move? Let's see. Okay, so this is the blurb, and I put it there in all its blurbness because it's actually quite hopeful to think about people thinking about HR like this. It doesn't feel like this on the ground, okay? But part of the idea of making this document was to encourage both administrators and managers, but also doctors who are leaders and others who are leaders to think differently about their teams, okay, and what is possible in the HR space. And we don't see this a lot, but you know, if we imagine if we could strengthen and encourage innovation, creativity, empathy, and leadership, it sounds amazing. You know, build adaptability in the organization. And so the truth of the matter is that most of us are not going to be the Minister of Health or director of a big department. We're going to be working in teams, maybe small teams. But if we can bring this kind of thinking to how we go about our daily work, I think that's where the key to this lies. And what's interesting in this document is that it takes the approach that if you look after your employees, you will look after your clients. I don't like that word. Okay, so your patients, the people who come in to use your service in the health setting. And what's also interesting is that they split this need into two parts. There's the need that you think you know about, your need to get your fracture seen to because you just broke your arm. Okay, but then the other need that you often, and in the South African public sector, almost have to kind of put away is your need to be seen as a person and cared for, and maybe even feel kindness and empathy from your healthcare workers, the people who you're interacting with, nurses and doctors and physios and whoever else, the pharmacist, we actually all want that, but our health system isn't set up to do that very well at all. And I think that's part of the dehumanizing that makes the health system itself so overwhelming. Because if we could rehumanize it, I think we'd be able to be doing better. So there's a model called the culture code model, which is kind of based on this pyramid that's at the bottom. We need to have purpose, and then we build values on top of that, change people's mindsets and behavior. Okay, and they're reasonably self-explanatory, but I like this kind of the deep and lasting reason for our existence. I mean, that does sound like, okay, whoa, we're talking about like healthcare, yeah. But actually, I mean, as much as you can go and have an existential examination of your kind of deeper self, and that's helpful, and I'd encourage it, you can do that as an organization as well. You know, like, why are we here as a hospital or a clinic or a OT department? Why are we trying to bring audiology services to a deeply rural area? You know, what is the purpose? And what is, you know, there's probably, if you go looking, and ideally, a shared purpose across all of your departments and work as a hospital. I used to try and promote this idea that everyone in the hospital, not just the healthcare workers, was inputting into that shared purpose. And I remember, and I quote her often, we had this lovely old lady who used to clean the floors in OPD. And she did it with such pride. Now, in our hospital, the place you entered the hospital was through the kind of the doors of OPD. And people always used to say how clean our hospital was. And this lady, the cleaner, came up to me one day and said, "Dr. Gaunt, have you seen how clean the floors are?" And, you know, I realized, number one, I must appreciate it more. But number two, our patients come in the door and they see the clean floors and the lack of, you know, rubbish lying around or whatever. And they decide, this is a place that I'm going to get better in. This is a place where people care. This is a good hospital. They haven't met a single healthcare worker. It's the cleaner who gave them that impression, you know, and the cleaner in this case is doing it because she's motivated to be part of the team that is caring for her community. And it's really profound. I guess goosebumps talking about it, because it's, you know, the patient has decided how good you are as a healthcare worker long before they meet you. You know, they've decided it because of the cleaner and the clerk and the nurse and the porter, and then they get to see you. And if that was a bad trail to you, you're on the back foot, to say the least. Anyway, okay, so then the thing is to articulate the values. What are these principles that are guiding our decision making? What are the bedrock that we can fall back on? And changing people's mindsets is a long-term exercise. You know, we often used to talk about influencing or changing a conversation, and that can take time. And it depends a lot on the environment that you're in as to how quickly that's going to happen, okay? But it's actually only the behavior at the end of the day that you see, and that other people see, especially your patients, okay? When we know who we are, and I like this, I wanted to put in here, you know, policies and even branding speaks to that. We designed a little logo, Zitilele, living the dream. And some people thought it was self-serving, but you know, my premise was nobody's ever going to apply to come to a hospital they've never heard of. And I mean, we were passionate about rural health and we'd never heard of Zitilele. So we were like, how are we going to recruit people if we don't get our name out there? So branding's important, actually. And every hospital has things about it and its location and its people that it can sell. But if it's absent, if there's no common purpose, if there's no set of values that's actually getting you out of bed in the morning, you find the dysfunctional spaces that all too often characterize public sector hospitals and other institutions. Okay, I thought this was reasonably obvious, but I put it in anyway. You know, leading through culture requires that what you say and what you do, you know, match. That you don't just talk about culture or values, that you demonstrate it. Okay, and you know, it's just really walk the talk. There's nothing that's different there, but the idea that culture is something that you focus on and that you talk about and live out as a priority is what I think is different, because a lot of the hospitals that I see that are struggling are a group of people who coming together to try and do work, but they haven't worked out fundamentally why they're there or how they fit together. Okay, and then I think the other key perspective here is this idea that employees and colleagues, employees, if you happen to be in the space of choosing them, but colleagues alongside you, you want to find the right people to join your team. You want to grow them. We all want to be growing and learning new skills, growing as people, and then we want to be able to keep them, and that might take a certain amount of flexibility and creative thinking. I thought this was also quite a neat graphic, so I threw it in there as well. Amanda, are they getting the slideshow? People are welcome to have a slideshow. You know, just how you move somebody from, oh, I'm so excited to join your team, to come and experience what you're doing here, to sort of really becoming part of it and feeling like they have something to contribute to. One of the things that we found made a difference for us was having people with a stated long-term commitment. So if you're in the position to make a long-term commitment, and in rural long-term is like 5 years, 10 years, 15 years, those are odd people like me, okay, 17 years, 20 years, there's some people who do that, okay, but stating that commitment up front allows other people, allows you to have a long-term view, okay, and allows people who don't necessarily see themselves sticking around for as long as that to come and be part of it short-term and not have to reinvent the wheel the whole time. And funnily enough, those short-term people often become at least medium to long-term people. We had so many people come for a year or two and then, you know, drag themselves away after 6 or 7. So this process, if you have a sense of how to take people through it, is important. And we'll come back to this one about helping people feel valued as well. Come back to it, isn't it? It's on the next slide. I think a lot of people focus on reward, and rewards are complicated. There's a lot of cultures that don't see tall poppies very kindly. So people are nervous to go the extra mile because their colleagues might say, well, you know, why don't you do all the work then? Especially if they're getting rewarded. Okay, but recognition is a much more kind of one-on-one behavior-focused encouragement. Okay, and that's what we're after. We need to be able to build each other up. There's so much negativity in the world. We don't need to add to it. And I think at medical school still, in many respects, and not just at medical school, in hierarchical organizations, there's some people who get their value from trying to put other people down, which is really kind of just sad and immature. And I think we can be bigger than that. And so as much as you might experience that toxicity as you know, juniors in a system, be it students or interns, comserves, that, you know, make a decision to not be like that is super important, and recognizing just the small stuff. It can be, I remember the very first compliment that ever got put in the compliment and complaints box about me was, I gave a guy crutches. Okay, now in 2005, wow, crutches were not freely available, but you know, we had some lying around, and I gave a guy who had a broken tibia crutches. Okay, that's pretty like bare minimum, eh? But he even helped a man who couldn't walk. And that was like, it was more my heart that they saw. Okay. Another example, that was somebody giving me recognition and feedback. But I remember, you know, just going back to the obvious, the rational need, and then the relational need. We had a patient, also back in the day, 2006, this particular example. He was an old man with an enlarged prostate, getting a date for the urology clinic, which was hopelessly oversubscribed at our tertiary hospital. Was usually about kind of 6 to 9 months, but he got booked a date, and he came back intermittently to OPD, and we didn't really do much for him. He saw one of the other doctors. There were only about 4 of us at that point, so continuity of care was a bit easier. And he saw that doctor a few times, and then after he had been to the tertiary hospital and had his problem fixed, he came back and he saw our colleague, and he said, "I never want to go there again." He said, "I want you to look after me." And I just thought, like, that for me was such a telling example. Again, early in our time there, they had fixed his problem. But, in fairness to them, they have such an oversubscribed service. It was in, out. It's sausage machine. Okay, and OPD can be a sausage machine as well. Because next, out, next, out. And the effort to just look someone in the eyes, put a hand on their shoulder, see them, engage with them, can so easily be lost. And yet that was what the old man had appreciated more than the fact that his actual ability to pee was better. So these are the 6 core values that we had at Zitulele. I now just call them my professional core values and put them on my CV because I couldn't part with them even when we left. Okay. No, I realized they really have become the values in the way that I see myself delivering care. So I couldn't even think of any others. Prioritizing patient care was core value number 1 because it needs to be first. And it's why we're there. And if there's any other thing that we put above it, you've got to ask yourself, why do we exist? It was also motivated. We still had that paperwork lady in the back of our heads telling us that if we hadn't written it down, it didn't count. We were like, no, patient care. Multidisciplinary teamwork. We experienced so much better outcomes, such better outcomes, and so much more fulfilling professional experiences ourselves by learning what our colleagues in the allied health disciplines and nursing had to offer our patients. And we used to have initially when we were small, ward round where we all went around and saw patients together, and later once or twice a week, all the professionals together presenting stuff that was maybe really basic. If you're an OT or a physio, you know how to, that's obvious. And then like the doctors are going like, wow, I never thought of it that way before, And every single discipline was like that. And bringing those different perspectives together made for better outcomes for patients. And as I said, better experiences as well. Respectful relationships. This was the hardest one because we're humans and we can frustrate each other at times. But I love this one. It's the head of the kitchen and the dentist. This is my wife with her back to the camera, the head of nursing, and our wonderful CEO, Mama Tebese. It was before the next one. Right. Anyway, this picture's used with permission. I always say that because it's quite a special and personal moment. I spoke about doctors delivering their babies at Zitulele, but this was our head of security, actually. He was the friendliest guy. We loved him. He was everyone's favorite. And the one night, as I was walking out of OPD, he came in saying, I feel a bit short of breath. I'm just going to OPD. And I was like on my way home Sunday night. Let me just follow him back in. And to cut a long story short, he ended up intubated in theatre because I phoned my friend who's an ICU specialist at midnight and said, Rob, I've done everything on the protocol. What else can I give somebody having a severe asthma attack? And he was like, the best 2 things in hospital are halothane and adrenaline. So we took him to theatre and gave him halothane and gave him an adrenaline infusion, and we saved his life. He came back to hospital 2 days later, walking. And I get goosebumps telling the story because every single time I saw him after that, I was like, I saved your life. But it was also the most terrifying moment of my whole career was intubating him when he collapsed in the OPD. And again, the care has to be good enough for you. And that was a very personal moment. The continual learning kind of interweaves with multidisciplinary, but really creating a culture where you wanted to be up to date. It's frightening how fast knowledge accumulates. You might feel like your heads have been stuffed full of knowledge, and you leave med school or whatever degree you're doing with this extraordinary amount of knowledge, and it's absolutely true. And then like a whole lot of things happen, like ARVs and protocols to treat hypertension in pregnancy or whatever, and it's like completely different. You have to stay up to date, and a kind of stated commitment to that as a team is important. And then what we just called core value number 6, a hopeful attitude. This is key to this topic of doing what you can with what you have, because it's very easy to become demoralized. And I wonder, when you look at this photograph, whether you see the kind of half-built, half-broken rondavel in the background that doesn't have a roof and that isn't any use to the family, or whether you see the clean washing in the foreground that speaks of a mother's love for her family, the time and effort. It's still very much a female role in the Transkei of going to the river and washing the clothes. And I think that's how we interact with the health system. What do you see when you look at it? The other part, so those are the 6 core values. How we go about our day-to-day work is also a matter of perspective. How you take the challenge of being resource constrained. You can have kind of 2 or 3 responses. I don't know if you've watched Free Solo. I highly recommend Free Solo. It's a documentary of this absolute nutcase called Alex Honnold, who free climbed, in other words, no ropes, El Capitan in Yosemite National Park. It's a slab of granite that's 1 kilometer high, 1,000 meters. I've stood at the bottom of it, and it's unbelievable. He climbed it with no ropes. Okay. Was that cowboy climbing? Was it courageous? Is he just nuts? Okay. And the same questions are true of the things you have to face sometimes in a rural setting. An example I use a lot was having a woman with severe fetal distress at midnight when our hospital had run out of oxygen. What's the right thing to do? Do you say, well, I can't take you to theatre because I don't have oxygen, and then wait 4 hours for an ambulance, another 2 hours on the ambulance, 2 hours in the queue there, dead baby? Okay. Or do you take her to theatre? And how do you take informed consent from a woman when she's not going to be able to understand the relative risk of a Caesar without oxygen as backup, but also you're asking her to choose between probably losing your baby or a really small chance that something could go wrong with a spinal anesthetic? Really hard, eh? What's the right answer? I don't know what the right answer is. I know what I did. I took her to theatre and I did a very careful spinal, okay? Because I still had 21% oxygen on hand. And I mean, my anaesthetist colleagues might think that was just nuts, because an anaesthetist is trained to work in a nice, orderly setting, but sometimes the rural hospital is not. So, again, I don't know what the right answer is, but I think if you make the decision just to protect yourself, I'm not sure that that's the right answer. And I work in medical legal, so it's like, I still don't think it's the right answer. I think you've got to engage your patient and make a decision together with her. Okay, this is just one other thing to put out there in terms of how we create these environments that allow us to do more. When I was a ComServ at Ngwelazan, we had 76 doctors at the beginning of the year, and about halfway through the year, we had 51 doctors. And about half of us were interns or ComServs, and we're a regional hospital. And so as a ComServ, I got to do laparotomies, gunshot laps, and all sorts of things in the middle of the night, which was pretty nuts. But the only reason I could do that was because there was a consultant who was on call every night to come and rescue you if you got into a dangerous current or piece of pool that you couldn't swim in, okay? So we were able to do crazy things. And I did. I once called my first nephrectomy at 3 o'clock in the morning, and I'd never done one before. And it was me and my wife, who was a ComServe, doing the anesthetic. Eventually I realized, no, I'm actually over my head here. It's 3 o'clock in the morning. I phoned him, and he came to come and rescue me, okay? And it's the same with questions. If you create an environment where people can ask questions, they are far more likely to go all the way up to the limit of their capacity, knowing that they can ask and not feel stupid, okay? Another example I've got there, I'm so glad you called me. Whenever I got called in the middle of the night to maternity and arrived to a crying baby, I would always say to the nurses, I'm so glad you called me. You know, I could, like, walking into labor ward at 2 o'clock in the morning when you've just dragged yourself out of a sleep, you could be like, you know, you didn't need to call me, you know. But if they're worried about the second stage of labor and they're worried about the baby, I would far rather know early in that process and arrive to a crying baby than have them go like, well, Dr. Gaunt doesn't like to be phoned, you know, at 2 o'clock in the morning. So let's give it another 5 minutes and arrive to a baby that needs like a full resus or maybe dies. Like, that's just about you and your attitude. It's quite profound, actually, because the impact on the health outcomes is severe, okay? So I was always aware of that and didn't want them to stop calling me because they felt nervous. And seeing as we're talking of questions, I try to throw this into all the slides. These are the two most important questions in healthcare. I'm just, yeah, this is a little segue. Where do you come from and how did you get here today? Okay, especially in rural care, but it's important here too, because if your patient here comes from the Transkei, that tells you a lot about them. They might seem poor to you, but they're actually one of the richer members of their family that they could get here in the first place. Also, they didn't come all this way just because they couldn't think of what else to do this morning. You know, they're desperate for healthcare. They've probably gone to 10 clinics and 3 hospitals and waited for the ambulance or the patient transport vehicle in vain several times, you know. So the Eastern Cape invasion of the Western Cape is a lot more than just like political words. It's like individual people who actually have a little bit of agency, at least, and a lot of desperation, okay? And understanding their journey of how they got to you changes that. I can't help. Just stop me at some point. No, don't worry. I'm nearly done. I have to tell the story about this because I think I consider myself really fortunate to have learned it as a ComServe. So I was in the surgical firm at Ngolazan, and one of the firms had a clinic on the Wednesday and did their surgery on a Thursday. And the other one, which was a bit less convenient, had a clinic on a Thursday and did the surgery on a Monday. Okay. And so I was in that one. And so it's Thursday morning, and the first patient in my door is an old Tata from near Manguzi, okay, further north than Kobuswek to Msileni, in the northeastern corner of South Africa. All right. And he was meant to have been here the day before. And I'm like, Tata, you were meant to be here yesterday so that you could have your surgery today. No, he knows. He's very sorry. Where he lives, it's been raining a lot. And he wasn't able to cross the river to catch a taxi to Manguzi Hospital, where he would then wait for the bus at midnight to take him 5.5 hours via the other hospitals collecting patients to Ngwelazan, where he would arrive in the early hours of the morning and wait for the clerks to then get his folder, to then come and sit on the bench and wait to see me. And he's really sorry because he wasn't able to start that process on Tuesday. He could only start it on Wednesday because of the rain. And I was gobsmacked. And I've told the story so many times and I still get goosebumps because I had no idea that that was what it involved for some people to access healthcare in our country. And I could so easily have just said, Tata, you know, come again next week on the Wednesday, you know, in youthful arrogance. And but when he told me that story, I was like, have you eaten? And of course, he hadn't eaten either because there's no money for food. And so I said, good, don't eat. I'm going to go speak to the surgeons. And he had his operation that day. So he taught me how important that is. And how you get here is as important as where you come from. Okay, right, back on to the topic. So the question that I hope you're asking yourself, or somewhere there in the back of your mind, is what is your sphere of influence? Because we sometimes think of the people who influence things as the people who've got the positions or the titles that start with a C, you know, the CEO and the clinical manager and other important people. Okay, those people are not any more important than the cleaner. They just have a different role. They get paid more because they carry a bit more responsibility, and sometimes they're the final decision maker. Okay, but this idea that we're somehow special because of our titles or our degrees or whatever is kind of anti this way of thinking. And it's a challenge to us as people, because of course we, you know, sometimes it's useful to have DR in front of your name, for example. Sometimes, you know, especially if you need better customer service at the bank or, you know, something. But the reality is, it's true. Our world is still like that, and that's actually not cool. And as far as possible, we actually don't want to be playing into that way of thinking. Okay, but at the same time, our privilege sometimes allows us to back other people up. So I just have another thought in my head, a story as well. A woman who'd been turned away so many times from Home Affairs, complicated stories about her and her birth certificate and her child's birth certificate. And it is amazing how complicated people can make their lives through some, you know, maybe not having an ID at the time they give birth. So they use the neighbor's name, and then the neighbor and them fall out. And then like I've seen every possible combination of weirdness. But anyway, she was trying to sort out whatever her problem was, and she'd been turned away many times before. And so, you know, I just wrote her a letter that explained what needed to be done, because Home Affairs put on their website the process that you're meant to do. So it's not actually a mystery, but the person at the front desk might act as though it's a mystery, you know, tell you one step at a time, do this, and then you go away and you do it and you come back and they're like, haha, now you have to do this. Okay. And so I could just tell her what she needed to do and gave her the letter, but now she was empowered with the knowledge, but then she had my letter as backup. And I think sometimes that's the way we can use our privilege, in a way that doesn't put ourselves front and center. Anyway, sorry, this is in danger of being derailed completely. The point is that knowing who you are and who you're influencing is super important. And I put there the time scale as well. I had a doctor ask me once, you know, what should they focus on in trying to make their hospital better? And my first question was, how long are you planning to be there for? Because if you're going somewhere for a year of community service, that's great. It's perfectly valid. It's just you shouldn't choose the 10-year project, okay? Because at the end of 1 year, you will have made a tiny little bit of progress, okay? Because most progress is kind of exponential, and you will have not seen the goals that you were trying to see. You will have frustrated yourself and probably frustrated the people there as well, who will be back to square one. Okay, and so you haven't, nothing's changed. But if you choose something that can happen in a couple of months, you can see that through and you can get benefit from it. Yeah, obviously, the people who come after you need to walk that same road and continue implementing whatever change that is, live that new reality. But you have to think about it sensibly yourself. And so your sphere of influence might be just the team that you're working with in general ward, or it might be a whole organization. Okay, and so sort of linked to this is this idea of mentorship, and it's quite, you know, in vogue to talk about mentors and life coaches and whatever, but it's quite simply Do you have someone to ask questions of? And have you created deliberate safe spaces for your juniors, anyone who might look up to you? Which is a weird, slow process as you get older. Suddenly you realize that, whoa, people think I know the answers. It's like, no. Okay, so like that happens to you as you get older. So the point is that you have the opportunity, regardless of how old you are, of having those relationships where you have people asking questions of you and you ask questions of someone else, and creating those spaces. We had a doctor's breakfast once a month on a Friday, and we would have a topic that we discussed and where we were able to be quite open with each other. And I think it was helpful. Yeah, and coming back to this title, at the end of the day, we're trying to achieve something simplistically. If we want better healthcare, that sounds so easy. Okay, but the truth is, I think, and there are lots of things that contribute to the reduction in hospital mortality in children. Okay, some of it was PMTCT, some of it was rotavirus vaccine. Very little to do with us. Okay, but getting it all the way down to, and I'm sorry I don't have the other years there. The slide I took this off had cut them off. But getting mortality down from 10% to 1% was about more than just rotavirus and PMTCT. It was about helping people connect with caring. Because when we first got to Zitulele, child death was the norm, almost. 10% is rough. In our maternity ward, 1/3 of women who were having their second pregnancy or more had lost a child, 1/3. That changes the way the community thinks about children. If you want 3 kids, you must have 4. Okay? Nobody thinks like that in middle class socioeconomic spaces. If you want 4, you have 4. If you want 3, you have 3. Okay? In poor communities, if you want 3, you have 4. Okay? And so imagine being the nurses. Imagine seeing 1 out of every 10 admissions die. And what that does as well. And what was amazing to see change was by the time we got to this point where we were under 2%, when there was a child death, it was a disaster. The nurses were crying. We would engage with our mortality meeting, like, what went wrong here? Sometimes within our power, often still not within our power. But it completely changed the way we did things. And so they go hand in hand. It's this caring that I think leads to better outcomes. And the better outcomes also lead to more caring. So it's a virtuous circle. I think there's 2 slides left and maybe 3, but they are kind of the caveat, the things to also remember, because it's easy to listen to some guy who went and spent 17 years at a rural hospital and sounds nice because we have a largely happy story to tell. It's also easier to forget the difficult things. Like you said, there's lots of pain as well, but we put that on the side. The truth, though, is that institutions and their capacity waxes and wanes. Government's capacity waxes and wanes. For example, you come into an election year, nothing's going to happen for 4 months. Okay, and then we'll be opening clinics and pretending we just built them. And then, the year will start once we've got a new MEC and whoever in place. That's part of the seasons. Okay, and the same with your colleagues. Our team changed like continuously around us. And to start with, it felt like the revolving door was going to slap us every time that December came around or somebody unexpectedly resigned. And then I realized also that I needed to change my mindset. It was actually, look at all the people who come to this place. I don't have to move, and I get to meet this extraordinary, continuous group, new people, many of whom we're still in contact with and have benefited hugely from their friendships over years without going anywhere. In fact, living in the back of Beyond. So it's a bit about perspective, but realizing that is also a reality and hard. Okay. And then also this idea of, are you in a place of high skill, poor attitudes, or low skill with good attitudes? Because your approach to creating change there or just surviving or trying to do more with what you have is going to be different depending on which space you're in. Okay. And then this is one of my favorite pictures that I've already heard you laugh at, because, you know, the plan and reality never quite work out. Ah, yes, 2 other outcomes. There were 3 slides. This is not a recipe for doing less work, unfortunately. Okay. When you care, you actually at risk of doing more work. Not just more work, you're at risk of burning yourself out from caring too much. And that's something that you have to be aware of, okay? Because it introduces a whole new challenge, and that is caring for the carer. Okay, when you start to, and I'm not advocating that you become emotionally involved with every patient, okay? There is a difference. I hope you perceive what I am and am not saying, okay? But the reality is, when you care at all, the needs and the pain and the suffering that you encounter in healthcare is very real. And if you're getting close enough to make a difference there, you're also close enough to get hurt, exactly as Cooper said at the beginning. And so that's something to be aware of. But on the other hand, it also creates teams unlike anything else. I was reminded, looking through something I'd written, that when there was a program about us on TV once, and somebody said to a colleague who'd actually been with us at Titulela, it must be so amazing to work in a place where people care. And when that filtered back to us at Titulela, we were like, huh? You know, but I think you'll know what I'm talking about if you've worked in a place where people don't care. It's very different. Okay, and this isn't to end negatively at all, but to be sensible, because doing what you can with what you have, there are also things that, you know, you can't do. And as much as that can be self-evident, I've written them down anyway. You can't meet the need. We asked a few seasoned rural veterans for their advice before we went to Zutulele, and this was one of the pieces of advice that we got. Don't go there thinking you're going to meet the need. The need is bigger than you, and it will outlast you, and it will kill you if you think you're going to try and meet it. So don't go for that reason. You can't provide perfect care, okay? You can aspire to gold standard care, but it's still not going to be perfect, and you can't do perfect care in almost every setting you'll encounter in South Africa, and certainly in the public sector. You can't save everyone. That's hard, but we want the best outcomes for the most people, okay? And sometimes I've seen people overinvest in what actually, with experience, you can tell is a semi-hopeless situation, okay, or a completely hopeless situation. And you need to be able to let go of those as well, so that you can continue investing in other places, okay? You can't do it alone. We were very lucky to have good friends, Carl and Sally LaRue, who came with us to Zutulele about 18 months after we got there. They joined us, and having at least one other couple with us made a difference. But even being a couple made a difference, okay? So an honest assessment of your life circumstances and your kind of friendship group, or whoever you could get to go with you, you know, honestly, it makes a big difference when you've got somebody who's got your back, okay? And I put there that you probably can't save the world either. We would love to save the world. I'd still love to save the world, but I'm becoming increasingly aware of the fact that I'm unlikely to do it in my lifetime. And this quote at the end, which I've alluded to already, but I think is important, because I think it helps us find the sweet spot of doing the most that we can with what we have. And that is this need to keep in balance enough dissatisfaction with the status quo that you want to keep making it better, okay? Because if you get that part wrong, if you get so dissatisfied, if you get so said this so many times in my life, and now it's confusing me. Okay, you want to keep, you've got to keep making it better, wanting to make it better. Okay. If you lose the desire to see it getting better, you become burnt out or disinterested and actually part of the problem. All right. And it's better to leave before that point. Okay. Or undergo some process of renewal. But you've got to want to see it getting better. But at the same time, you have to have an ability to live with what isn't perfect. Because if you can't handle the chaos or the lack of X, Y, and Z, then you get frustrated and cynical and burnt out as well. And you also leave. Okay, so if you are hoping to be in the system and create change, whichever part of the system that is, you know, you have to be able to hold these two things in balance. I think in some ways we have to hold those in balance just to live in South Africa at the moment. We have to keep hoping that we can still live up to our potential, okay? And we have to be able to tolerate what isn't perfect at the moment so that we are still here when we live up to it. Like I said, it's a little bit more philosophical perhaps than what you thought, or maybe you thought, what the heck is he going to talk about? But I hope that what I've said at least challenges you to think maybe a little bit differently about your career, your role in your space, and yeah, how you approach the very real challenges. It's, you know, one of the challenges just about of speaking positively is that it can seem like we're pretending the negative isn't there. The negative is there. It's challenging. It's practically assaulting us day in and day out. Okay. But if we want to make the most of the skills that we've been privileged to acquire and make a difference in people's lives, we do that by being there. And hopefully this will give you some tools to do that. That's all from me. Thanks very much.
Thanks, Ben, for a very inspiring talk, and I'm so glad you did tell us some stories.
Couldn't resist.
Yeah, you said you wouldn't, but you did share some of them, and I recognize some of them from the book. That was one of the things I told the students about, how I read your book in December, and that they have to attend. So I'm glad to see some of the student faces here. Yeah, thank you so much. One of the things I've learned is that I'm part of a club of weirdos that stayed longer than 5 years in rural.
Yeah.
Yeah, 16. Yeah, indeed. And yeah, talking about values, that's really something that's close to my heart. I had an epiphany when one of our speakers of the Rural Research Day that's going to present tomorrow, Paul Worley, delivered a plenary on values, and that values are actually much better predictors of who's good clinicians, those that live according to their values, than marks. And he was challenging the whole system, him being a dean of a very prestigious Australian medical school. And that really got me thinking. But thanks again.
Thank you. Happy to. Yeah. If you have questions here, or are there online questions? Amanda, are you going to tell me what to do?
Yes. Don't have anything on the chat.
Okay.
People can put up their hands.
Don't be shy. There's no such thing as a silly question. I covered everything. There's nothing left to say.
I'm just curious, why did you have to do a nephrectomy?
So he was a gunshot. He was a very large man who'd had a gunshot abdomen, and it had gone through the lower pole of the kidney. It was bleeding quite a lot, and I didn't know how to stop the bleeding without taking it out. Yeah. So I'd seen one. So we did see one, do one, teach one in those days. Preferably leaving out one of the steps. Then it was like high grade. No, so yeah, so I mean, I just thought his kidney wasn't going to stop bleeding. The correct answer was probably that it might have, and a more skilled surgeon would have done something different. But I got the kidney out fine. It was just that I couldn't tie off the renal artery because he was very big and everything kept getting in the way. And so the surgeon came out and he held it and he tied it off and he says, "Yeah, otherwise happy?" I'm like, "Yeah."
Wow.
But it's that mix of like, was that a cowboy thing to do? I mean, it was me. I had the knife in my hand. It's 3 o'clock in the morning. There was nobody else on call with more surgical experience, little though I had, you know, and it was, but it's the ability to knowing that someone had my back. And that makes all the difference. Because in fact, there was another time when another surgeon was on call as the consultant, and this guy was just bleeding from a stab wound in his axilla. And I don't know if you know anything about the anatomy of the axilla, but I didn't. I mean, I did sort of, but yes, it's a different thing when you're digging around the axilla at 1 o'clock in the morning. And I didn't know what I was after or how to even approach the axilla. And the surgeon was like, "No, don't worry, I think you'll be fine." And I was like, "I am not fine." You know, and it was terrible. I was just so happy when he woke up and he could still move his arm, because I was like, I could have tied off anything in there. And I felt like that's like there I was over the line. I didn't really have a choice. He was bleeding actively and I had to stop it. It was me again. But I felt like I was out of my, you know, what was safe. And I didn't get help. And contrasting those two things was really helpful for me when I was later the clinical manager, you know, being people knowing that they could phone me whether or not I was on call. My phone was never off, because bad things happen at unexpected times. And the other part, I mean, another story, but I was at Christmas Day, and we were literally getting ready for lunch, and then I got called. I wasn't on call, and I got called to the theatre. Woman was bleeding, and then, you know, lunch was at our house. So I phoned Carl, and I was like, "Carl, can you go and see what's happening?" Anyway, so Carl went, and then I get a phone call, "Ben, can you come to theatre?" Now Carl and Sally are already in theatre helping, and then I went as well. And that was, you know, it was fine. But then a month later, it was my daughter's birthday. I think she was turning 2. And literally we were about to cut the cake, and I found out there's a woman bleeding in the theatre. I'm like, "No, man, this is ridiculous." I definitely didn't have a sense of humor about that one. And when I was complaining to my mother later, she said, "Well, I hope if I was bleeding in theatre, there was a doctor who'd be happy to leave his child's birthday party to come save my life," which tells you something about my mother, but also that no, but she had the right perspective, hey? Because I mean, like, yeah, look, being there for your kids is super important, and that's one of the cool things about rural is that your kids are there with you. But yeah, it also just helped me to see it differently. So that's and obviously for the woman who was bleeding, and also for the doctors and nurses who were trying to help her, made the world of difference at some point and actually help, because there's nothing worse than losing a patient or harming a patient when you were operating at the limit of your ability with all the good intention in the world, and it still goes wrong. And especially if you knew that help was just there and they didn't come, because then you've undermined everything that you've ever said, really. So that's yeah, but it's challenging because it does mean that your phone's always on, well, it did for me in that setting. Yeah. So getting the balance right is hard.
We do have some really lovely comments in the chat.
Thank
People
you.
acknowledging how thought-provoking, insightful, and inspiring the talk was. And we'll get those printed for you so you can remember them.
Thanks.
And thank you very much, Dr. Gaunt.
Thanks. Can I, before you clap, I want to say that, you know, for us, it was a tremendous privilege working at Tutelele. And to be honest, we thought we'd be there until we retired. And that wasn't how it panned out. And people ask us if things changed, would you go back? And my wife goes like, yes. And I go like, okay. I don't miss the unions and the politics, but I but I do miss the patients. But that wasn't what I was going to say. What I was going to say was it was such a privilege working there. And yeah, and I think, I mean, I obviously appreciate the kind comments, but I also think that each one of us can do that. Like, we're not special in any way. Like, I'm nothing about me that's special. I'm just a normal human being. And so, like, I hope that part of our story at Itulela inspires each one of us to say, what can I do where I am? And in some ways, that's also what this topic is about. It's about, you know, do what you can with what you have. It's not just about scarcity. It's also about who you are and what you have, and realizing that you can make a difference as well. Yeah. Cool. Thank you.
Question?
Oh, there's a question? I can't see the question. Where's the question? Oh, there, I can see it.
Abby,
Abby,
please go ahead.
Oh, sorry, Vin, it's me. I raised my hand, and I just wanted to thank you in terms of exactly the question that you answered, doing what you can with what you have. And ideally, it's about you, the individual. And so, I mean, it's not a question, but it's really just a comment around why this was so inspiring to listen to. Because maybe to your CV, you should add your connectedness as a human, you know, and that passion to serve, and that honesty with which you uh, portray or tell your experience. Because I think that I dragged the students from my module to this webinar from WITS, and it's about that point of influence that you have to carry. And so, yeah, I just want to thank you for those inspiring words.
Thank you. Thanks very much. Yeah, cool.
Hello, I have a question.
Yes, go ahead.
Yes, I don't know if I'm opening another can of worms or what, but I'm a student. I'm a final year student working in Sirius, a part of the LIM program from Stellenbosch. So during, I think in 2022, I did my elective at Ngulatan Hospital in internal medicine. And I saw that the doctors, they really struggled with patients who use like traditional medicine. And I don't know if you have also encountered that during your time working at Zitulele Hospital, and maybe if you did, how did you go about in addressing those issues? Because people in the rural areas or in the rural side are still like very strong on traditional healers and getting traditional medicine, and yeah.
Yeah. No, that's a great question, because what you have is also the circumstances that you find yourself in, and the reality is that you know, many people, particularly the very traditional communities in rural areas, but actually in urban communities, people try all sorts of herbal remedies. They just buy them at clicks, and so it's similar. But yeah, I think the first thing, certainly as a junior doctor, I would often find myself kind of what I would now call arrogantly angry at the harm that I saw being done from traditional medicine or some traditional medicine. And I think that as I spent more time, you know, in the game, realized a few things. Firstly, there are a lot of people who use traditional medicine that don't come to harm. So it's not that traditional medicine, which is such a broad catch-all phrase. I mean, there's so like, what is traditional medicine? Like, we almost use it as a kind of an antithesis of Western medicine, but that's not even accurate either. So it's like the catch-all phrase has got such a variety of stuff in it from very innocuous things to very harmful practices. And so I think being aware of that is important, that not all traditional medicine is harmful. And then also really important, realizing that in the vast majority of cases, the person giving the traditional medicine, and I think some of the hardest ones are when kids are involved. Hey, like, I mean, an adult who takes traditional medicine and ends up, causing harm to themselves, that's in some ways their own issue. Like, there's no law against, making bad decisions. So the adult I'm less worried about. The kid who comes to harm because of a harmful traditional practice or medicine that's been administered to them is a lot harder. But even there, remembering that for the vast majority, the person who gave the medicine was trying to help, not harm. So, gogo or mom or even the traditional healer, we're not trying to give the kids hepatorenal failure or, kill them. And I think that changes a little bit how we as health care workers in the Western model respond to that, because the reality is that, some medicines are harmful, but the intent was good. And that changes again then how you interact. Remember, you need to keep mom on board. Like, even if she loses her child, like, she's going to be broken from that. And you need to see her humanity and engage her in ways that allow her to heal. And even, she's going to probably never speak to you about that aspect of her grief at all, but how you respond to her is super important. And then you can, once you win people's trust and once they see that you're there with the same goal, i.e. the health of their child, then you can start to what we called change or influence the conversation. A little the same around contraception, for example. Contraception wasn't something that people necessarily felt was their right or that they could access. And I was like, why do you think that? Have you thought about this? What about that? Just starting to ask questions and put options in people's heads. And so, with traditional medicine, the harmful things, we did kind of engage, and we engaged the traditional healers as well. I think one of my happiest moments was 2013. We had this big meeting, and there was a launch of some government program, and the Traditional Healers Association stood up and said they decided they were going to tell their members that sick 1-year-olds must not be given X, Y, and Z. They must rather go to hospital. We were like, that's incredible. And so I think that that wasn't something we negotiated, but I think I'd like to think it anyway, that something of the kind of engagements that we had with the traditional healers, not that we shared their worldview. I still can't get my head around some of the dichotomy, but another patient experience, one of the very senior traditional healers in the area who we engaged with, he had diabetes, and he used to come and get his insulin from the hospital every time. And I was like, I can't completely understand, but we got on well, and we could talk about it. And in his construct, there was TB that traditional healers treat and TB that must go to the hospital. And I'm like, I don't know how you tell, but that's cool. It's like, these are the ones I think need to come to me. Okay, the other ones, call them whatever you like. No, but and just when he eventually ended up dying of a sarcoma. And I remember my last interaction with him, just saying, I knew it was going to be my last interaction with him. And I wanted to say to him that I really appreciated the way he was always able to engage me. I was a doctor, white, from outside, and yet I always felt welcomed by him. And I appreciated what he had, been able to reach out to me. And he said similarly nice things back, which was very kind of him. But I realized, wow, it's those things. And I didn't like everything I saw. And obviously, for some people as well, other spiritual stuff in the background that might make it even harder to engage with. But at the end of the day, you know, we aren't, again, it comes back to kind of how we see ourselves, and do we see ourselves with the humility that we probably need to, or do we see ourselves as having all the answers? And I think realizing that, well, A, I didn't have all the answers anyway, and two, I couldn't get, you know, it wasn't for me to judge some of those practices. Sorry, very long answer to your question. It's not an easy topic, and there are really difficult things that one sees and engages with in that kind of sphere. And it's I would also add that it's even harder at regional hospital level, hey, when you're getting referred all the disasters from all the district hospitals, and you don't have any connection to those communities. So you just feel hopeless and maybe angry that this is what you're dealing with day in and out. Whereas if you're in a district hospital or a clinic in the community, you know who the chiefs are, you know who the traditional healers are, you know where that Tsotsi who calls herself Sister Rose and who gives poison. You know, we actually went and engaged her because she was trouble and she wasn't a proper traditional healer. You know those people, so you go and you engage them, and that's a little advert for rural medicine, because being close to the community is cool. Yeah, long answer. Hope it was helpful.
Thank you so much. It was very helpful.
Amanda, we did it.
Thank you. Recorded nice. Thank you, everybody, for joining us. And I'm sure we'll have more webinars to come. And thank you for your time. And thank you, Dr. Gaunt.
Yes.
I just want to remind you that the front gate will be closed. So if you drive out, please use the gate to the start.
Yeah.
Tea and cake.
Ooh, tea and cake.